Okay, let's talk about brain tumors. So brain tumors typically are in males more than females. There's two different types, primary or secondary. Primary is that it arises from the tissue of the brain itself. It doesn't come from another origin source. Secondary is that it results from metastasis. So if you've got somebody, for instance, that has breast cancer and on their follow-up PET scan they see a tumor on the brain, that brain tumor is a secondary brain tumor. It's not the primary. It didn't arise from the brain tissue. It metastasized from another source. If you look at table 5612 in your book that is on page 1333, there are different types of brain tumors described in detail. Just look over this. You're not going to be tested specifically on this type presents itself like this or this type presents itself like this. There's a couple that you may be familiar with more than others, like glioblastoma has been talked about in the news some just because it is very, very highly aggressive, very malignant, typically progresses pretty fast with a poor prognosis. There may be some other ones that you may be familiar with as well. I do want you to know that about half of the brain tumors are malignant. Some, depending on the location and what the tumor actually encompasses, like if it encompasses a large area of cerebral vessels, they may be inoperable, and that's whether it's malignant or benign. And in some cases, part of the tumor can be removed to cut back on some of the complications from the tumor, and in some cases the tumor can be removed completely, and then in other cases that it can't be removed at all. Here's clinical manifestations of brain tumors. A lot of these are similar to increased intracranial pressure, clinical manifestations as well, seizures. The other big thing with brain tumors is headaches. Headaches are very common with brain tumors and typically worse at night. If you look here to the right, this diagram shows you, dependent upon what lobe of the brain the tumor may be located, it'll tell you what it may affect. For instance, if somebody has a tumor in the occipital lobe and you're getting a history and physical on them and they're really complaining of visual disturbances, and you do your physical exam and you're seeing a cranial nerve deficit within the oculomotor system, then you're suspicious, okay, there may be a tumor or a lesion going on in the occipital lobe. And so from that point, after you've done your history and physical, you're getting diagnostic studies that the provider has ordered. First initial test is CT scan. It's cheapest, it's quickest. It'll pick up a lot of tumors unless if they're small. And in that case, if they're still suspicious or have reason to believe that there's a tumor, they can order an MRI. PET scans are typically done for patients that already have cancer, but still, that can be ordered for somebody that doesn't have a history of cancer and they're suspicious of a brain tumor. There are other tests that are done as well. For instance, cerebral angiography. If they have a tumor on an MRI and it looks like it's enveloping a vascular system of the brain, then they can do the angiography to determine that. They also could do an MRI with contrast, and that may show them enough detail. If not, then they would do this angiography. EEG to rule out seizures or to evaluate seizure activity secondary from the brain tumor. In order to actually diagnose the brain tumor, as far as what kind of brain tumor it is, whether it's cancerous, benign, what type of tissue it is, to determine if it's a glioblastoma or one of these other brain tumors, meningioma, they would have to get a tissue biopsy. Goals of treatment are aimed at identifying the tumor, knowing the location of where the tumor is at, removing the tumor altogether or decreasing it by partial removal, and definitely managing the ICP. Treatment, surgical therapy, like I just discussed. If they can have surgical therapy, that definitely does extend their survival time, and it definitely does decrease ICP immediately after surgery and the complications from increased ICP. Shunts may be used for patients that have hydrocephalus secondary to the tumor pressing on the outflow of the cerebrospinal fluid. If it is cancerous, chemo and radiation may be an option. For those patients that have a glioblastoma, like I said, it's very, very aggressive and very malignant. This Optune system may be another option. It's kind of a newer treatment where they'll actually place electrodes similar to like EEG electrodes on the scalp, and they'll put it over the tumor location. And what it does is it delivers this low intensity electrical current to the tumor site to help reduce its size some. Goals, again, as far as nursing management, would be maintaining normal ICP, preventing any quick increases in ICP, trying to maximize all the neurologic function that you can, achieving pain and control of other symptoms like nausea, vomiting, keeping nutritional status up, and in that you would do high protein, high calorie diet, small frequent meals, and definitely plan ahead. You know, if you see that there's going to be some long-term physical effects or cognitive effects that may be permanent, just preparing the patient and the family for those with education. You may see some, and this is a big thing, a big adjustment for patients and families, more families. Depending on the tumor location, they may have a lot of behavioral or complete personality changes. Depending upon what lobe's affected. And with that, you have to provide safety. So not only are you thinking about safety if this patient has seizures, but you're also thinking about safety as far as self-harm. This may be secondary to overwhelming depression regarding the diagnosis that they've just received, or it may be that this patient that typically has never had any sign of psychiatric disorder or any signs of hurting themselves or hurting others, now you're concerned about that. So, you know, you're looking at the environment. Are there any cords that they could use for strangulation? You're just making sure that there's not anything where they could hurt themselves. And you can read through the other ones of these on this slide. The other thing that is important toward the end is end-of-life care discussions. That should be done very early. Once a patient is diagnosed with a brain tumor, that conversation with the provider should happen very early. These are the expected outcomes. Just evaluate your implementation just to see if they've been effective. Moving forward, now we're going to talk about cranial surgery. If you'll look in your book, this is on page 1336 and 1337. Table 5614, this shows you indications for brain or cranial surgery. And some of those would be a hydrocephalus where they'll have the shunt, a brain tumor like we just discussed. Some other things can be if they've had trauma to the skull, they may have skull fractures to where they need cranial surgery, or if they've got a brain abscess that needs to be drained or removed. Aneurysm repairs would fall into this category. AVM malformations. Be familiar with the types of cranial surgery, 5615. I'm not going to ask you every little detail about the surgery, but I want you to be familiar with the different procedures that they can do. As far as nursing management for cranial surgery in the pre-op phase, explaining the procedure, answering any questions after they've had the procedure explained, and that's both with patient and family, and very much providing emotional support. In the post-op phase, very frequent nursing neuro assessments, and they may start out every 15 minutes, and then it may be every 30 minutes, and then it may move to every hour, and then from every hour to every 2 hours, and then to where you no longer need frequent assessments. Fluid and electrolyte levels and vital sign frequent assessments. Manage their symptoms, pain and nausea, vomiting. Look at their dressing. Make sure that you don't see an acute bleeding or frank bleeding. If there is blood on the dressing, make sure to mark it with a marker, date and time it, so the oncoming nurse can see if there's a change when they do their assessment. Keep the head of the bed elevated to 30 degrees, and that's with most surgery cases, unless if the MD has an order or the provider has an order for otherwise. There are a couple approaches like the burr holes or posterior fossa approach where they'll actually want you to keep the patient flat. Craniectomies, you don't want to position the patient on the actual operative side that it was done. And you just want to do anything to prevent a quick increase in ICP, like straining, some of the things that we learned earlier on in this chapter, so just keep that in mind. As far as discharge, getting back home, the overall goal is just to keep them as independent as possible. Moving forward, inflammatory conditions of the brain. The examples of this that we're going to talk about is brain abscesses, meningitis, and encephalitis. So brain abscesses is an abscess in the brain. So it's a pus pocket that's sitting within the brain tissue. And this can be from directly a local infection in the brain, or it can be secondary to a systemic infection that they've had. The primary organisms that are typically caused in these abscesses are Streptococcus or Staphylococcus aureus. These symptoms are going to be similar to meningitis and encephalitis, and we're going to talk about in a minute. Headache, fever, nausea, vomiting. The symptoms or manifestations that patients will present with are similar in all three, so a good H&P and diagnostic workup is important for these providers and these patients to determine how to treatment and how to get them better. They will have signs of increased ICP, and diagnostic studies would be the CT and the MRI. Initially CT. Primary treatment for a brain abscess is antibiotics. Any other symptoms that are secondary from the abscess, like any kind of nausea, vomiting, or headache, those can be treated as well, but primarily antibiotics are used to treat the local infection or the systemic infection. If the abscess is not showing a response on CT monitoring, as far as the decrease in size, their white count's not coming down, their temp's not budging any, they're still having hyperthermia, then at that point is when the neurosurgery team will decide whether they need to do surgery to either just drain or remove the abscess altogether. Bacterial meningitis, this is the inflammation of the meningeal tissue surrounding the brain and the spinal cord. This is a very, very serious condition. The mortality rate is about 100% if it goes untreated. So it does require reporting to the CDC so they can monitor for outbreaks of this. You can see the leading organisms that typically cause this. H. influenza is not so much anymore now that we have a flu vaccine. It's more your top two there. But do know that these organisms do typically enter through the respiratory tract. It can enter through the bloodstream, but it's typically through the respiratory tract that we see bacterial meningitis etiology. It does produce increased CSF production. These patients will have extra secretions around the brain due to that increased production, and they'll have increased ICP, cerebral edema, and they can herniate. Key signs, headache, fever, nausea, vomiting. They can have nuchal rigidity as well, and they could have some of these other symptoms here. If they progress to a coma, it is a poor prognosis. Make sure that you're familiar with your assessment as far as neuro. Go back and look at Koenig, Brzezinski sign. Make sure you know those. Complications are secondary to the increased ICP. And depending on what area was affected, what load, they may have permanent deficits, and they may not get that function back. Another condition down here is Waterhouse-Friderichsen syndrome. This can be secondary to meningitis, in which the patient actually bleeds out. They have DIC, petechiae, adrenal hemorrhage, and circulatory collapse. Basically, they go into kind of a hypovolemic shock secondary to bleeding, and this is just due to the bacterial meningitis affecting the vascular system. Diagnostic studies. Now, in this case, they will get a lumbar puncture, and that's the most indicative way to determine bacterial meningitis, because they're doing a gram stain and a culture as far as a white count on that CSF fluid. Now, they will get other tests as far as additional lab work and a blood culture to see if it's systemic infection as well. And they're definitely going to want to get a CT, MRI, or a PET scan to determine if they've got an abscess as well. So, interprofessional care, providers and nurses. Drug therapy, you're going to see IV antibiotics for this to treat that bacterial infection. Codeine is typically most effective for these kind of headaches. They will use dexamethasone IV corticosteroids to decrease the cerebral edema. Aspirin, or you don't really see aspirin in this case, it's acetaminophen they use for the temperature. And they may put them on prophylactic IV anti-seizure drugs, IV mannitol, that will help with the dexamethasone to decrease cerebral edema. So for us as nurses, it's administering these medications that are ordered in a timely manner, being proactive, watching your vital signs, doing your frequent neuro assessments, providing rest for the patient as much as possible, IV fluids, and manage their fever. Some of these patients, may get Tylenol every 4 to 6 hours and they're still remaining with a fever. So in those patients, it's calling the provider and saying, hey, can I get an order for a cooling blanket? Now, in getting this patient a cooling blanket, the biggest thing is that you don't want to drop their temp too rapidly, because if they have a temp that drops very rapid, then they're going to shiver. And it's okay if they shiver a little bit, but some of these patients can shiver so much that it looks like they're seasoned. And that in turn causes another problem, because it's going to increase their ICP. So you want to gradually reduce their fever. Planning, biggest goal is maintain neurologic function, resolve the infection, control their symptoms. Health promotion, as nurses, encourage our patients to get vaccinated, pneumonia and flu vaccines, as well as meningococcal vaccines. And we do see that more now than what we used to, but continued education and promotion of vaccines is important. If a person has been exposed to bacterial meningitis, some providers you can provide prophylactic antibiotics, and a lot of providers will do that. So nursing implementation, you can read through these. Most of these we've talked about. Some of the other ones would be, just avoiding external stimulation, trying to keep their environment calm, quiet, darkened. If they've got photophobia or they're having seizures, you don't want to try to reduce any kind of stimulation. Safety, you want to make sure their fluid status is okay. I mean, if they've got a fever and at this point they may be going into a type of septic shock, then they may need a lot of fluids. Watch your urine output, watch your vital signs. These patients will be under respiratory isolation until the cultures come back negative. Ambulatory care, these patients are going to need lots of rest even when they get home. Just educate them to slowly increase their activity. If they're having a good day, don't go out there and walk 3 miles. Just take it easy. Nutrition, high protein, high calorie, small, frequent feeding. And evaluate. Evaluate that these measures that you've implemented are effective. So the difference here in viral meningitis versus bacterial meningitis is that it's viral. So antibiotics aren't going to help this patient. It is through respiratory secretions. These patients as well will be on respiratory isolation. The disease typically is self-limiting, and it's just symptomatic management. Manage the fever, keep them hydrated, keep their nutritional status up, provide rest, treat headache, nausea, vomiting, any kind of symptoms. And the diagnostic is the same, lumbar puncture, as well as additional tests if needed, labs and CT imaging. Encephalitis is different. It's just an inflammation of the brain as a whole. It's most often caused by different viruses. Symptoms: fever, headache, nausea, vomiting, just like the other ones. And the signs typically appear in 48 to 72 hours. Early diagnosis and treatment is the most favorable as far as their outcome, and that would be doing CT, MRI, PET, EEG. Now, in this one, they can do viral titers to determine what kind of virus that they're dealing with, as far as one that we're aware of. Herpes simplex virus is a common one that they're going to test for. If they're in an area that's endemic, they may check for West Nile. Nursing interprofessional management. If you're in an area where this is an issue as far as a country, mosquito control for prevention. In the South, that is a big thing. They do have people that spray for mosquitoes. Management is symptomatic and supportive care. and they can use antiviral. So if somebody comes back and their titer shows that they have HSV and they think it's related to herpes simplex virus, then they'll put them on antivirals like acyclovir to help reduce the symptoms. And that's it. If you have any questions at all regarding this lecture, please reach out to me, and I'll be happy to answer your questions. Make sure to do NCLEX test review questions. Prepare yourself for this exam. Thanks.